Thank you, Sam, for that kind introduction and for the invitation to come and do your very first ever panel. It's my very first ever as well, so let's see how it goes. You've already halved our time, so all the planning has gone out the window, but I think we're going to have we've had a fantastic morning, haven't we, of really, really top quality information. So we're just going to use the time that we've got to distill that and flesh things out a bit. And what I'm going to ask, I'm not going to change this bit, I did ask each of the speakers, because we started now at least a couple of hours ago, just in one or two sentences, what's the main take-home message they want us to go home with from their presentation? Starting with Ben, you started at the beginning, so...
Right, if I were to crystallize my sentiments, it would be as follows. One, insulin resistance matters. And two, we need to detect and treat it better. And that will come from improved focus on diagnostics within the clinic, as well as acknowledging that this is not a problem that can be cured with a drug.
Great. Roy, you were next.
Thank you. I think my take-home message would be, wait. That is something we've got to get real about. If we look back to the photographs of you at your primary school and compare them with what you see in current day at the primary school gate, you'll see what I mean. It's there. We've grown bigger, and it's now regarded as normal. So, for instance, our recent study looking at people with normal BMI and type 2 diabetes, of course, if they lose weight, they will lose their diabetes. It's the same disease. But this has been lost, and it isn't yet in medical practice. So there are some crashing simplicities here, because the metabolic determinant of what happens to your food is actually inside your organs. And if they're clogged up with the fat, they're not going to work well. So weight loss.
David, your take home.
I can remember a time when type 2 diabetes was rare. And what worries me is that as my generation of doctors die out, nobody will remember that it's perfectly possible for type 2 diabetes to be rare. And so there is urgency, real urgency, that while we know it's possible, we must get cracking. Prevention, absolutely key. It's a window of opportunity. And I don't want us to forget that we can do this. It's perfectly possible. I do not accept the pandemic of diabetes. It's not necessary.
Absolutely. And Helen?
So I wanted to make sure that you've remembered we are offering low-carb, real food health coaching on the NHS at the moment. And that to survive, we need to grow TLC, we need more people to come and commission us, and we need to raise money for our research study. So please support.
And on that note, I'd like to pledge £500. If Jen agrees, if Jen agrees, cancel that holiday. £500, I really approve. And it's doubled now, so that's a start. That's 2% of it sorted. Yeah.
Right. Ben, then just fleshing out from what you were saying. I mean, I absolutely loved your term "plagues of prosperity." I've not heard it put quite like that before. But what I think we need to understand, it's a plague that's no longer just prosperity. And I think, I've done some work in sub-Saharan Africa where rates of type 2 diabetes they're thankfully still much lower, but they're increasing because those plagues are getting everywhere. You showed how the constant feeding is driving the hyperinsulinemia and the insulin resistance. What can we do about that?
Oh, right. Yeah, so I appreciate you appreciating my ongoing efforts to make things memorable when I speak. I want something to stick. And this is certainly born from me trying to teach 20-year-olds and keep them engaged. My philosophy on teaching, as an aside, is to outcompete social media, which is not easy to do at any moment.
Excellent.
So The plagues of prosperity, also Weston Price and others Mike Eads has referred to them as the diseases of civilization. I just have such an affection for alliteration that I always make an attempt to do it. So the problem is primarily chronic hyperinsulinemia. Now, that is not to say that the stress and the inflammation don't matter. They do. And I have published manuscripts on this, and I appreciate them. But it's difficult. I'm not a clinician, but I could imagine an interaction between a GP and a patient. And then let's just imagine that the GP knew what the patient's insulin levels were. Not hard to do, very easy. Let's say that the GP knew what the stress levels were based on the primary hormones, specifically cortisol and epinephrine. That's how a professor who teaches advanced endocrinology defines stress. And then let's say they knew what the inflammation was, perhaps based on C-reactive protein measurement. And let's say they were all high. And then the GP says to the patient, well, you have all three of the primary causes in your body. And then maybe the patient says, all right, well, then how do I lower my stress? There's not an easy answer. It's difficult. If there are three levers on the wall, stress, inflammation, hyperinsulinemia, the first two are very slippery. It's difficult to know why the stress hormones are elevated. It's difficult to know why the inflammation markers, the cytokines, are elevated. It might be an autoimmune disease that's just poorly understood or not even identified, or a food sensitivity that you just don't know. So as much as the first two matter, and they do, when it comes to practice, they matter less, unfortunately. But it does enable us to focus on the hyperinsulinemia. That's my long-winded way of getting back to your question. Not to come back to an idea that you've already heard, I wish I could think of something novel, but I really come back to those pillars and maybe because you'd started with the constant eating, which we do. We have a culture where we become uncomfortable having an empty stomach. Like there are people who say, I need to eat, my blood sugar is going down. No, it's not. You're addicted to feeling full, which is a real addiction. We speak about certain foods. I'm addicted to this sugar. I'm addicted to this drink. Some people are just addicted to feeling full. And when they start to feel empty in their stomach, they panic. And David showed the idea of hunger. David Ludwig, one of my collaborators at Harvard, and you cited some of his papers, he has found that when insulin goes up and the overall availability of nutrients in the blood goes down, that the brain senses that and gets hungry, because the brain doesn't have an energy storage. The muscle has energy that it can use. The liver has its own energy. The fat cells, of course, have plenty. The brain needs constant sampling from the blood. And so if blood nutrients go down, which insulin will push down, the brain says, I'm going to run out of energy. It has a very high metabolic rate after all. It's an engine that needs a lot of fuel. It will try to stimulate hunger. Anyway, I'm taking too long. Eating too much, rather eating too frequently, is a perfect way to ensure you are living every waking moment in a state of elevated insulin. So to come back to your point, if nothing else, now I believe very strongly that managing the macros matters.
Yeah.
Managing macros matters. And when you do that, it enables you to fast better. Because if you've become accustomed to using your own fat for fuel, then the brain doesn't panic. It doesn't sense. It doesn't care what's in the intestines. The brain cares what's in the blood. And if you have ketones, you have fatty acids, you have glucose at a normal level, which you will fasted, then the brain won't sense it. So maybe I'll flip everything around and just say fast frequently. And then you do that by managing your macros.
So manage your macros, fast frequently. Roy, you wanted to come in, and I was going to ask you a question next anyway, so yeah.
Just a comment about what Ben has just pointed out. 3 levers on the wall. But really the question is, what's the effect size of each lever? Now, stress is a difficult thing to measure. We know it will produce the effects that Ben mentioned. But it doesn't seem to be that effective if we take away the primary metabolic other drivers. Inflammation. Treatment with anti-inflammatory agents makes no difference to metabolic state. There's no evidence it's on the direct pathway, it's just there. Effect size, contentious, certainly not large. Hyperinsulinemia, yeah, no, that's a major player. As Ben mentioned, the effect on appetite, for instance. Yes, those are very real things. But we need to bear in mind that the hyperinsulinemia can be just abolished by the weight loss. I didn't show you all the metabolic data, but the insulin level was normal in our counterpoint study at 7 days. That's 7 days to metabolic health. So take away the insulin resistance. Remember, the liver, which demands attention because it controls everything, is pouring out the glucose. Take away the insulin resistance from the liver. Incidentally, you don't change it in muscle at all. That, we could come back to that. Then the hyperinsulinemia goes away. So we shouldn't look at that as primary necessary in the strict sense of the word. We should be looking at this central matter of weight and its effect on metabolism, and the fact that weight in one person is not the same as weight in another. So someone can be metabolically healthy when they lose weight from a BMI of 45 to 42 or 25 to 22. And we see that across the range of our studies of weight change. So yes, the hyperinsulinemia is in there, but when we look at effect size, I would say there's a huge lever that's on the wall, and that's the effect of weight in an individual.
Thank you. If you keep the microphone, because I was going to ask you that it's clear, isn't it, that really what we're talking about with this metabolic ill health is a big, big insulin problem, hyperinsulinemia, insulin resistance. And yet, as clinicians, we can't measure insulin. Is that part of the problem, do you think, as to why doctors tend to think of type 2 diabetes as being a sugar disease rather than an insulin problem?
Not
Would it help
really, not
if we
really.
could?
There have been a swathe of studies looking at the measurement of insulin or its clever correlate C-peptide to see if it could guide clinical management, and it doesn't. The reason is we are individuals, we're so variable, and our insulin levels we measured in this room would vary tenfold at least. Our glucose levels, much less than that. So it probably wouldn't help in a direct sense, but recognizing that the combination of high triglycerides with even marginally raised glucose are warning signs, and if those are coupled with some weight gain, since you stopped growing, which was probably the age of 21 or so, get real. We need to get back to that healthy state of 21. So if you can't fit into the waistband you wore when you were 21, that is an indicator of possible metabolic ill health.
And I find that that's a really helpful message that everyone can identify with if you're talking to a patient. And, you know, can you remember what was your weight or your waist in your 20s? Part of what we've got to accomplish in this time is how we're going to save the NHS. The NHS, as we know, is guided by NICE, who come out with guidelines. The NICE type 2 diabetes guideline was written in 2008, and I think at that point, Roy, maybe not even you knew that remission was possible then. It has been updated a couple of times, but the updates have been about drugs, because the focus is still reducing glucose levels. So how can we influence the messaging that is being disseminated out there as best practice to being more than just SGLT2s and GLP-1s?
Calls to mind Bernard Shaw, who I think pointed out that doctors know a lot about drugs and nothing about people. So NICE is looking at drugs. That's their focus. And they've spent the last few years building up to a reconsideration of drugs in diabetes, despite comments from the sidelines, not only from me, from Jonathan Labji, the head of diabetes for NHS England. And so we have a problem with the mindset of NICE. There is no sign that NICE wants to take on board the new understanding of type 2 diabetes to see that weight is a primary thing that has to be changed. Now, because weight is coming into their purview with these new weight management drugs, it's just possible they may wake up and lift their eyes. But we have a problem. NICE was created as a monster to manage the health economy by drug management. And that setup is problematic, and we need to just be aware of that. But somehow, we can't abolish it. We've got to work with it, and exerting what influence we can on other bodies to bring this to attention is all we can do.
So that's a really good point, and yet NICE guidelines are common. You know, GP colleagues will often talk to me about the NICE guidelines, NICE guidelines, NICE guidelines, and it's great to remember NICE was set up actually to talk about drugs rather than anything else. Maybe so. David, did you want to mention something there?
Yeah, we've got to find some hope, haven't we? I think there's some hope through our independent royal colleges. We have something that the rest of the world has not. Our royal colleges are independent. And my call really is for the Royal College of General Practitioners to get behind the idea of incentivizing quality of care for people with diabetes. Because at the moment, you know, I am not paid anything for getting type 2 diabetes remission. We don't get a penny for that, and yet it's a wonderful achievement. Shouldn't really GPs be, how about £1,000 for each patient that you get into remission to help pay for better quality care? That makes sense. We are not incentivizing quality of care. Pre-diabetes, there is nothing in the QOF, so our incentives are managed through QOF. There are no QOF points at all for helping people with pre-diabetes get a normal blood sugar. This is the low-hanging, easy fruit that if the Royal Colleges would look at quality, not just in terms of a poor aspiration of managing it below 56, let's aspire to get normal blood sugars. And I think we need to look at incentivizing primary care. That's one suggestion that I've got. And I hope to have a big article tomorrow in one of the major press to lead and call for this specific thing. Thank you. Let's hope it's there. Let's hope it's there. My second point is so much of this has been a grassroots revolution. I learned from a patient back in 2012. Many doctors have learned from successful patients. And I'm hoping as the grassroots revolution grows, eventually the politicians will take notice as we grow and grow and grow. And that's why I struggle every day with Twitter, and many of you help me. I'm trying to get through Twitter and now through media great interest in what we're doing and the idea that we can do better. Thank you.
Great. So I'd like to come on then to the initiatives that you've spoken about, which have been so successful in helping people achieve remission. And what's come through, I think, is the issue of maintenance and supports on an ongoing basis. And I'd like to explore that in a bit. But before we do, Roy, in your 5-year data, I think it was 13% are still in remission. Do you have any pointers as to what characterizes those? What's kept them in remission? You alluded to some of the success factors, but is there anything from those data that can help inform how do we help people maintain remission?
The huge point that sticks out a mile is the weight. Those are the people who maintain their weight loss by and large. The average weight drop from baseline was about 9 kilograms 5 years out. They were still in remission. So the weight is a number one. Other things, such as the level of HbA1c at the start, doesn't matter at all. Some of the people who respond best have got HbA1cs of 100 or 110, but tend to be quite large, and they respond magically. So no, there are no major predictors apart from that which declares itself weight, and the best predictor of maintained weight loss is the early weight loss. If people don't lose weight in the first week or so of a low-calorie diet, they're not going to do well, because they're not following the diet.
Well,
Because energy expenditure is almost irrelevant compared with the energy you can take in with a single biteful. So We do know there's a good early predictor, but the ultimate predictor is weight.
Thank you for clarifying that. Helen, if I can ask you to take the microphone. So you've overseen this pilot for the Lifestyle Club. You're demonstrating already some really good results. How, and potentially, because it's actually relatively low cost, and you're going to be Kismet accredited, which means GPs get points. So lots of things going for it. But what's your plan to save the...
So if I can remember all my points. The first thing I wanted to say is it's not until people set themselves goals that they realise that they are actually stopping their own, they're setting their own limitations, in that you'll set a goal, I'll run 2K, and only when you've run 2K do you think, well, actually, I could probably do 5K, and then before we know it, you're running a marathon. So a health coach needs skills, and it takes time to help somebody to develop those goals and to think through what they want to do to personalise their approach. It takes time to do that. The Grassroots Revolution that David's talking about, I think that health coaches will be able to empower people to demand that, to go to the government and say, this isn't good enough. I know that I have other options here, and I want them, and I'll vote for them. So I think it all starts with health coaching alongside the existing health system to actually drive it from the bottom up. My final point is it's got to come from a charity, because there's no money to be made in eating real food. So it has to be a charity that's going to do this.
Fantastic. And I can come back to Ben to just develop a little bit further. I think the reason why maintenance is so important and the follow-up is so important is that you've lost all that weight, but you're still surrounded by a very toxic environment, particularly in terms of food. Certainly in the UK, and potentially even more so in the US. Over here, governments have shied away to really try and do anything to control this constant feeding that we're all subjected to, and temptation. Is there any signs of hope in your side of the water that things might change, that policymakers are recognizing the issue of this chronic overeating?
No. No, unfortunately, it seems every effort, I bet a lot of you are familiar with Nina T. Schultz in the US. She has been such a wonderful advocate and for changes to the dietary guidelines within the US, and she has rallied a significant amount of support, all to no avail with regards to public policy. Every time that it seems like there's going to be some change, it just goes right back to status quo. If there's any evidence, perhaps, if I maybe put some sort of optimistic spin to this, it would be the dietary guidelines, although they don't call it that, for the American Diabetes Association. In 2020, one of their statements, although it was buried at page 20 out of 100 or something, it was so easy to really overlook, it was not emphasized, but they stated that the best available evidence, that was a quote there, was supported for improving glycemia was carbohydrate restriction. And that was quite novel for them to admit it. Now, those of us who are rational would say, of course, eating less carbs helps control glucose. But it's amazing how irrational a lot of this is. So no, I'm not overly optimistic at a federal level, but there is maybe a hint of improvement with regards to some individual societies. But again, in the next breath, the American Diabetes Association is going on and on about the benefits of a low-fat diet. And now just to, if I won't hijack the conversation much, but there is, David had mentioned this as well, there is evidence. One of my frustrations with clinical trials is that they will take two groups, split them up, and they will both be on a low-calorie, low-fat diet, and the same isocaloric, low-carb diet. The enormous confounding variable, this false paradigm that is born from this, is to say that, well, look, lowering insulin doesn't matter. But insulin is the hormone of the fed state. That's how it was originally described. My issue with these kind of dietary trials is that a low-calorie diet is going to be a low-insulin diet, because insulin cannot stay elevated if energy intake is down. If insulin were high, that would be comparable to taking a diabetic, say fast for 24 hours, now I'm going to give you 20 units of insulin. What will happen? They will go unconscious because the insulin will push all the energy out of the blood, and who needs constant sampling from the blood? The brain, and so the brain will turn off. So there's this enormous confounding variable of every trial that has ever compared, even weight loss, with Roy's interest. When you look at weight loss with a low-fat diet or a low-fat, low-calorie, and often always low-calorie, low-carb, you always see a same degree of fat loss or weight loss because they both lower insulin. So what needs to be done is what Sam did. Sam's N of 1 trial, where he tried to get fat. Good luck with a guy like Sam, right? But he saw which diet. So what needs to be done is a hypocaloric diet that tries to say which diet can they get the fattest on. Is it a high carb, high calorie diet, or is it a low carb, high calorie diet? Then we'll have an answer to the question. But one other comment. I appreciate Roy's focus. I'm sorry for hijacking this for just a moment.
It's all right.
I very much appreciate Roy's focus on fat mass. Really, when people say, what kind of scientist are you? I say I'm a fat scientist, because that's what we're doing. We're taking fat biopsies from humans. We're taking out all the adipose depots from the animals. I'm not countering what Roy's saying. I'm not truly. But I don't think when we just focus on fat mass, mass matters, but it's not the amount of fat per se. It's the size of the fat cell. For example, you have people who are paradoxically fantastically obese. In the US, we have documentaries about these individuals, unfortunately. And they'll be 600 pounds. And if you measure their insulin resistance, it's normal. That should be impossible. Interestingly, in the US, I suspect here in the UK, do you guys use thiazolidine diones, PPAR gamma activators? I bet you do. I think you do here. I bet you do. There's this class of drug that will take an overweight diabetic, and you give them this PPAR gamma activator, a thiazolidine dione. This is like rosiglitazone.
Pioglitazone, yeah.
Okay, yeah, so you have them. So what the GP will notice, the patient certainly will, is that they begin taking rosiglitazone, and over the next 6 months, one, their diabetes gets better, but they gain, I don't know, a couple stones of pure fat. And yet they're getting less diabetic. It's because this drug is making their fat cells reproduce, which helps the bigger fat cells start to shrink a little bit because it can share the fat with the smaller fat cells. This is why women will have more fat than her male counterpart but be more insulin sensitive, because her estrogens will help new fat cells grow, much to her chagrin, mostly on her butt and hips. But nevertheless, as much as mass matters, and it does, it's more about how is the person losing the fat mass? Back to Roy's point, if they lose fat mass, insulin sensitivity gets better. I completely agree with that. I would just add to that, it's because the big hypertrophic fat cells are shrinking.
Thank you. I'm getting signals that we need to wrap up. So if you could pass the microphone on to David, just each of you, one final very short point, if you have one that hasn't yet been mentioned.
So it's all about maintenance. And a patient called Elizabeth said to me, she said, Dr. Unwin, this isn't a diet. Low carb is a great way to live. It's a lifestyle. A diet is a thing you fall off, and you do it for a short-term purpose. We have to aim for a lifestyle that people enjoy and celebrate.
Really good point. Roy, any final message?
The only way forwards is to tackle the problem at source, as you mentioned, the food environment. Because we have food companies that are spending vast amounts donating to each political party at the moment in order to prevent exactly what you've mentioned. We've had childhood obesity strategies that have been about to roll and then have been quietly scrapped, or not so quietly scrapped. But the critical thing is to keep on at MPs to draw their attention to how basic a problem this is for the whole society. That alone would really make a huge difference to the NHS.
Absolutely.
So in January 2019, I set myself the goal of walking to work, and it was a 20-minute walk, maybe 25. And I thought, I'll listen to a podcast. I listened to Zoe Harcombe telling me that the dietary guidelines were all rubbish and the Eat Well guide was hopeless. And so I arrived at work, my job being a food technology teacher at a secondary school, and I just thought, what am I going to teach? And then here I am with all my absolute heroes at the Crucible in Sheffield. I am so optimistic of what we're going to be able to achieve. Thank you.
What a great note. Do we have any questions to field from the audience?
So one that's been coming up a lot is that, weight loss has been discussed here, but what's everybody's opinion on the Ozempic drug? Do we have concerns over that? Or what are our
I'll
thoughts?
start this, and then I'll be as quick as I can in all
30
sincerity.
seconds.
Yeah. So I have a particular interest in these GLP-1 agonists because back a long time ago, about almost 20 years ago, and I was in my PhD lab, it was one of the first labs who had a grant from Johnson & Johnson in the US to study the specific effects of these incretins, these hormones that had just been discovered from the gut. And that discovery came from gastric bypass procedures, seeing how drastically these hormones change in this fantastically obese type 2 diabetic. And a week later, there's no more diabetes, and yet they're still fantastically obese. Now, there's a lot going on there, but part of it was thought to be because of this increase in incretins. So Ozempic is a GLP-1 agonist that was originally designed for diabetes. And at the time, when it was just a diabetes medication, I looked at it quite favorably. Now that it is being prescribed at multiples of the dose for weight loss, I have much more concerns, and they are as follows. So one of the mechanisms of action of these GLP-1 agonists that no one appreciates is that they induce adipocyte hyperplasia. I just mentioned a drug, rosiglitazone, which has a person gain weight, and at the same time, paradoxically, they're getting more insulin sensitive. GLP-1 agonists stimulate new fat cell growth. Now, however, you're thinking, but Ben, they lose weight. That's because these drugs also induce lipolysis. At the level of the fat cell, it's activating fat breakdown. So even though there are more fat cells, they're all shrinking, so overall mass is going down. That's a good change. At the same time, what's contributing even further to the weight loss is the incredible nausea that the person is feeling. Incredible to the point that many people stop taking it after a few months because they just get tired. They get sick of feeling sick. So eventually, whether it's because of the nausea or whether it's because of the incredible expense of the drugs, because they are not cheap, they decide to get off the drug. Now they have the return of all the cravings that they thought were gone. It was a drug-induced improvement in cravings. They hadn't actually gotten over their cravings at all. So here come the cravings back to them. And they have more fat cells than they did before they ever took the first injection. You can imagine the consequence. And there are no long-term studies to measure the degree of weight regain, but we know at 2 years in, at 24 months, the sweet cravings come back, even though they're still on the drug. So even the nausea is temporary. And so as the nausea subsides and they have more fat cells than they did before, I think we can anticipate significant weight gain.
David's about to grab the microphone from you.
Yeah, I got to say, the word is paradigm. We've got the wrong paradigm. When will we learn that we must swim upstream to find out the cause of the problem? How is an injection anything to do with the cause of the problem? The answer cannot be to drug all our young people with obesity. We need to find out, why are they heavy? What makes you hungry? And look into that. This is a distraction. We've had many, many distractions over the years, and it's because we have the wrong paradigm. We must think about the causes of the modern diseases of civilization.
I absolutely would of course agree with that. I would just add, though, as a clinician, that drugs do have their place, and GLP-1 drugs can be helpful as an adjunct to someone who's trying to lose weight, possibly because it helps reduce their appetite, possibly just because it's made them nauseated. But I would always say to people, these are there to help you with your lifestyle change, and the aim is it's time limited. The problem with the way they're being churned out is you go on the drug and you don't need to worry about your lifestyle because the drug does it for you, which it doesn't. It makes things worse.
The lowest possible dose.
Yes.
If the person's going to be put on Ozempic, I would say never go on the Wegovy dose, which is simply the same drug at 5x the dose or whatever. Do the lowest possible dose and get off it as soon as possible.
A great message really for any drug, if possible. Sam, were there any other questions you wanted us to ask? Then we're going to wrap up. I think, ladies and gentlemen, you've had a real treat this morning. We've heard from Ben how the main problem is in so many diseases is hyperinsulinemia. We've heard from Roy, who showed before anyone else how tackling that can help reverse type 2 diabetes. We've heard from David before most other people knew that it could be done, how he's done it in his own general practice. And for the future, we've heard from Helen how hopefully this organization can help make that mainstream and available to everyone. What a great session. Thank you for sharing it with us.
Right. Wow. What a morning. Amazing. Thank you, Dr. Cavan. That was a brilliant session, and to all the panelists. Now, before we go to lunch, which will just be in a moment, don't worry, it's coming, we have a special award to give somebody, very special. And to give that very special award is our benefactor, and from the Bennett Foundation, Steve Bennett. So if you want to come up, Steve.
Wow, what a morning. Thank you all. Wonderful. Sam asked me he said, so we can do it by committee and work out who to give a trophy to. And committee doesn't always work, as we know. So he said, could you just think of somebody that works for the PHC to give a lifetime award to? And that was really, really difficult because everybody, Helen, Sam, the whole team are absolutely wonderful. And, I'm so proud to be associated with you guys. You're all absolutely incredible. But Sam insisted I pick somebody. So my thinking went something like this. In business, we look for somebody that goes up and beyond what they're paid to do. So I started there. And I thought, let me find somebody that maybe surprises everybody. And I looked at that. And then I thought, no, that wouldn't be fair. So anyway, a little bit about this person. I'm going to give you a clue, those that know him. He used to have a pig in his garage at home, and he lived in a cul-de-sac. So go and figure that one out. And you don't know that about him, most of you. But a bit of a strange character, this one. But this one I really, really fell in love with many years ago. My dad's diabetic, and I got involved after hearing a message from this gentleman about how it's not chronic. It doesn't have to be. It can be reversible, and without drugs. And sadly, my dad still doesn't listen because he thinks myself and all my doctor friends are all quacks, and he'd rather listen to his doctor, who sadly missed the fact that he had erectile dysfunction, high blood pressure, gout, and all these other things that could have said that eventually he'd end up with diabetes. And sadly, he's still on injections, Ben, for type 2, which we all know puts his cancer risk up and his blood, his chance of heart disease up. But the message has got to get out there. And last week we saw on the front page of the Express something that David helped write to get the message out. Anyway, cut a long story short, behind every good man there's a great woman, and this could easily have gone to your wife, by the way. But what David's not mentioned yet is that part of his success at his Norwood GP surgery, part of his success is for many, many years, Jen, his wife, and himself, every Monday, not paid for, in the evenings, have run a clinic to help those with diabetes. And I think it's that extra work that has helped you get those results, unpaid for. Just fantastic. So based on that, based on everything we're seeing in the news, the fact that together, yourself, your family, and Sam, put this charity together, and without which, and by the way, I've been to a lot of these around the world, this is by far the best. It really is by far the best. Without your work, David, really, we wouldn't all be here today, and I think the message would never get out. So I'd like to give a Lifetime Achiever Award to Dr. David Unwin.
What can I say? Just thank you so much. Thank you. And thank you to Jen. Has she gone to the loo? She's still here. It really should go to Jen. Thank you from the bottom of my heart. Thank you so much. I have nothing more to say. Thank you.
Nice one, Steve.